Hello everyone. As we all know, March is observed as Colorectal Cancer Awareness Month across the oncology community. On the occasion of this Colorectal Cancer Awareness Month, in this month, March 2022, I would just like to have a brief presentation and important points for the general public to know about colorectal cancer. I am Dr. Rajesh Kota, Senior Medical Oncologist working at American Oncology Institute, Vijayawada. So if we look at the colorectal cancer, we have to see the anatomy first. So we all know that the human digestive system starts with the mouth. When we eat food, so when we look at the anatomy of the human digestive system, it starts with mouth. So we take food from our mouth. So the food gets traveled through the esophagus, that is also called the food pipe, to the stomach, where it starts getting digested, taking the help of pancreatic juices and the liver enzymes. So from the stomach, partially digested food goes into the small intestine, and from the small intestine, the residual fecal matter goes into the large intestine, where water gets absorbed and the solid fecal matter comes out of the rectum and the anal canal. So this is the brief anatomy and physiology of the human digestive system. So from the mouth to anal canal, we call it as the gastrointestinal system or the digestive system. So among all these components of the human gastrointestinal system, today we will be talking about the colon and the rectum, that is the lowest part of the digestive system. The large intestine again is divided into three parts, that is the ascending colon, transverse colon, descending colon or sigmoid colon, and then rectum, which ultimately joins the anal canal. So cancers of the GI system, the most commonest occurs from the colon and the rectum, that is the lowermost part of the digestive system. So how does this cancer start? So it starts as a small polyp in the glands of the lining system of the large intestine. Sometimes it can start as an ulcer, small ulcer, non-healing small ulcer, which later develops into cancer. So if we look at the statistics, in India, colon or the rectal cancers, that is the colorectal cancers put together, among men and women put together, it constitutes the 5th commonest cancer in India. So breast is the most common, followed by lip and oral cavity cancers, followed by cervical cancers, followed by lung cancers. Then comes the colorectal cancers. So usually around 65 to 70,000 new patients get diagnosed with colorectal cancers every year. And they get diagnosed in different stages. So the earlier we diagnose, or the earlier stage we diagnose colorectal cancers, which can be done, I'll tell you how we can diagnose early, the better chances of survival. So if we look at the statistics from the United States, which is the developed country and where medical facilities and awareness among the public is highest, it is the second leading cause of cancer-related death, even though it can be prevented, or death can be prevented if diagnosed or treated early. It still is the second leading cause of cancer-related deaths. So right now, there are more than 1 million survivors of colorectal cancer in the United States. So an average individual will have a 1 in 20 risk of getting colorectal cancer in his lifetime, in his or her lifetime. So as the age progresses, our risk of getting colorectal cancer increases. And as I said, colorectal cancer starts as a small gland or an ulcer in the large intestine. If we can pick up those ulcers or glands that are abnormal in the initial stages, we can diagnose them early and we can prevent the death that is because of colorectal cancers. So as high as 60% of the deaths related to colorectal cancers can be actually prevented by doing early screenings. So if we look at the risk factors at the first place, why should men and women get colon cancers or rectal cancers? So there are certain risks that can be modified, and there are some inherited risks that cannot be modified, or that risk factors that are not in our hands. So if we look at the risk factors that are not in our hands, the first and foremost is family history of colon cancer. If some of your elders familially has got colon cancer, your mother, father, grandfather, grandmother, maternal uncle, maternal aunt, or paternal uncle, paternal aunt, you generally tend to have a higher risk of getting colon cancers. As I said, the average risk of getting a colon cancer is 1 in 20. So it will get doubled or tripled. The risk gets doubled or tripled if you have a family history of colon cancer. So that we cannot change our family history. The other risk factor that cannot be changed is age. So as I said, as population ages, the risk of getting colon cancer or the risk of getting rectal cancer increases. And we cannot modify our exposure to UV light. So this is not in our hands at least. And if we have got a personal history of polyps, those are small glands in the large intestine. If for one reason or the other, our intestines get these polyps, so they can get transformed into colon cancers. So that also we cannot modify. And some people will have inflammatory bowel disease, or there will be some mucosal injuries. The intestines get damaged because of internal reactions to the existing bacteria in the intestine, and the mucosa gets inflamed. Inflamed meaning it gets damaged. So in those conditions also, there is a future risk of getting colon cancers. Risks we can change. The first and foremost is being obese and living a sedentary life is a risk factor for getting colon cancers. So those two are one of the few risk factors that we can modify by doing regular exercises and keeping our weight in control. We can reduce our risk of getting colon cancer. Uncontrolled diabetes and smoking and high intake of red meat, lesser intake of diets containing fruits, vegetables, and fiber increases our chances of getting colon cancer. So I would request all the audience to quit smoking and increase the fiber, vegetables, and fruit content in your diet and keep your diabetes in control. So these are few modifiable or risk factors that we can change that are in our hands. So these things can be done from our end. So when should you suspect something is going bad in your digestive system? So not all symptoms are relatable to cancer. So there are a lot of vague symptoms that indicate that your system is not working properly. Your gastrointestinal system or the digestive system is not working properly. So one of the symptoms is blood in your stool. So every now and then people complain that I have noticed some blood along with my stool. So most of the times it might be due to hemorrhoids. The common term we use for hemorrhoids is piles. So sometimes people might have fissures, anal fissures. So that can also cause blood to be present along with the stool. So most of the times they might be the underlying cause. So people often neglect if these blood in stools for hemorrhoids and fissures. So if it is a long-lasting phenomenon, I would suggest you to consult your general physician or a family physician, and if needed, get it checked with a gastroenterologist. So blood in stool should alarm you to get checked by a doctor. Not that all patients having blood in their stools have colon or rectal cancers, but that warrants or that is a warning symptom for you to get tested. People complain of this abdominal pain or abdominal bloating sensation. So again, this is a vague symptom. Not all patients with abdominal pain or bloating sensation have colon or rectal cancers. There are a lot of reasons for people to have this abdominal pain. If it is a long-lasting phenomenon, again, if it is the pain is there for 1 or 2 days, you can basically take some over-the-counter medications. But if the pain lasts for a week or so, if it is long-lasting, not getting relieved with your over-the-counter medications, again, it is a warning sign that you must get tested. You must get checked with your family doctor or a gastroenterologist. Again, if for one or the other reason you get your hemoglobin checked, and for all men, if they are having low hemoglobin, they should get the reason known. So men should not have low hemoglobin as such. So for all adult men, if there is a low hemoglobin, that is a warning sign to get checked if there is any blood loss anywhere in the system, not just the GI, anywhere. So all men with anemia or low hemoglobin should consult a gastroenterologist, and if needed, they'll ask for a endoscopy, that is a small camera viewing your upper gastrointestinal system, that is the esophagus or the food pipe and the stomach and the first part of the small intestine. So if you find some ulcers or lesions that cause blood loss, so they'll suggest appropriate treatment. Likewise, the blood loss can be from the lower gastrointestinal system, that is from the colon, that is the ascending colon or the transverse colon, descending colon, sigmoid colon or rectum. So if they find polyps or ulcers, they'll do a tissue testing, otherwise called as biopsy. So in that, they'll know what is the cause for this blood loss. So low hemoglobin or anemia warrants a gastroenterology consultation, and if required, endoscopy and colonoscopy should be done for all adult men. Likewise, in women, if they have attained menopause, before menopause, women generally have blood loss in their menstrual cycles. So there will be menstrual blood loss. But again, if the blood loss is and the hemoglobin value, the anemia is disproportionate, so again, those women should be tested for any additional blood loss that is happening through the gastrointestinal system. Likewise, all post-menopausal women, that is women who have achieved menopause, there is no source of blood loss for them usually. So if those post-menopausal women are also having anemia, they need to get tested by a gastroenterologist and look for sources of blood loss from the GI system. The other sign of colorectal cancers is loss of weight or unexplained weight loss. So if someone is doing exercise, not taking enough food, or if someone is on a diet routine to lose weight intentionally, then it is fine. But if unintentionally you lose, say 10% of your weight, so if you are around 80 and let's say in 3-4 months time you become 70, 65 without any intentional cut down in the intake or without any excess exercise, so that should warrant you that something is not good in your system and you should get checked by a gastroenterologist or your family physician. The first point of contact should be a family physician, and he will thoroughly check you and refer to a gastroenterologist at appropriate time. And some patients complain of changes in bowel pattern. For a week or so, they'll have constipation. The very next week, they'll have diarrhea. So this alternative constipation and diarrhea, or some patients will have chronic constipation. Some people will have chronic diarrhea. So all these things which are not routine, which are not usual, should be checked by a gastroenterologist. And if required, they'll do a colonoscopy. Again, I want to reiterate that all these symptoms are vague, non-specific. They warrant a checkup by a doctor. So if people having these symptoms go early to a doctor, they'll check appropriately, do proper or relevant investigations. And if at all any disease is diagnosed, not just cancers, any other diseases, ulcers, polyps can be diagnosed. So if they are diagnosed early, we can treat early, and life will be comfortable both for the patient and the doctor also. So what does blood in the stool tell us? So blood in the stool, that can be easily noticed by everyone, that it can be due to a polyp or an ulcer or a cancer. So blood in the stool for a long time should not be neglected. So that is the take home point I want all the youngsters to notice. And rectal bleeding is a sign of colorectal cancer, and it is the most common sign most of the times. So if we take the history or the symptoms from a patient, the most common sign or the most common symptom we get is bleeding from the rectum. And diarrhea alternating with constipation is one more common thing. And the stool size, some patients will have strictures. The large intestine gets narrowed down because of the ulcer, and a stricture is formed, and the size of the stool gets thinned out. So patients complain that they are getting pencil thin stools, so or ribbon like stools. So because of the constriction of the large intestine, patients will get decreased stool size also. That is also one important sign of suspecting a colorectal cancer. Again, change in bowel habits, as I said, either too much of diarrhea or too much of constipation, or alternating diarrhea and constipation. All these are signs of something not good in the lower GI system, and that needs to be checked. Something called a feeling of not emptying completely, or whenever a patient or whenever a person wants to empty his bowel, it might be painful. So that is also a cause of that should also be not taken lightly, and it should also be investigated. It is a cause of concern, that feeling of not completely able to empty. Weight loss with no known explanation. As I said, if you are unintentionally losing weight, that should be investigated. Abdominal pain, it can be in any form, like bloating, fullness, cramps, and people not able to eat even though they are hungry. All these are vague symptoms but warrant investigation. Anemia is the most common symptom. It is a sign. It is the most common sign we see in colorectal cancer patients, because they have microscopic blood loss that sometimes cannot be noticed in the stool also. So most of the patients have bleeding per rectum, and if the cancer is from the ascending colon, the bleeding might not be obvious. It can be occult. So we don't see the blood along with the stool, but even then there is some occult invisible blood loss. So there we see these low hemoglobin levels or anemia. So unexplained anemia in an adult male or a postmenopausal woman, disproportionate anemia in females during their menstrual age also needs to be investigated. Anemia or low hemoglobin leads to fatigue and weight loss. So fatigue can be due to anemia. So this also should be investigated properly. So as I said, If we diagnose the disease early in stages 0 or 1 or 2, we can treat easily. The treatment is much more economical, much more easier. The time for treatment is also shorter. So as the disease progresses and as we diagnose patients in stage 3 or stage 4, that is the disease has spread to other parts of the body, treatment is costlier, outcomes are not as good as the earlier stages, and there is a lot of morbidity to the patient also. So that's why the importance of screening. So these are all the different methods of screening, but most commonly what we test is fecal occult blood test. That is, we take the stool sample and test for any blood in the stool. So what does blood in the stool tells us? That there is some blood loss across the gastrointestinal system, be it the upper gastrointestinal system consisting of the food pipe and the stomach or the small intestine, or the lower GI system, that is the large intestine rectum. So if there is blood in the stool, which is not even seen with a naked eye, but it can be tested by doing a guaiac test. So that if we notice blood, or if the test comes positive, we have to investigate for sources. We have to identify the source of blood loss in the GI system. So that is the most common test we do, which is non-invasive. You just have to give your stool sample and the lab determines whether the stool sample contains blood. The second most common screening tool we use is colonoscopy. Colonoscopy is nothing but a flexible plastic tube with a camera at the tip of the tube, and a gastroenterologist uses it to view your lower gastrointestinal system. So they insert through your anus, look at the rectum, sigmoid colon, descending colon, transverse colon, ascending colon, cecum, that is the first part of the large intestine, and they can view a small part of the terminal ileum or the last part of the small intestine. So what the gastroenterologist sees here is, or the colonoscopist sees here is, they'll have an opportunity to view your colon or the large intestine from within. So from inside, they look for ulcers, polyps, any signs of cancer, any strictures, narrowing or inflammation. So all these signs can be physically or directly viewed with the help of the camera that is attached to the tip of the colonoscope. So this is the direct way of looking things inside the large intestine. And colonoscopy as a screening test is advocated in India for patients having a family history of colon or rectal cancers. In the West or in the developed countries, people, if they attain an age of 50, they'll have a colonoscopy at the age of 50, and from there on, every 10 years, once in every 10 years, they'll get a colonoscopy done. So that is part of the screening schedule for cancers in the West. But here, because of our vegetarian food habits, or our diet contains fruits, vegetables, and a lot of fiber, the incidence or the occurrence of colon or rectal cancers is lesser when compared to developed nations or the Western world. So that's why it is not part of a mandatory screening program. But if patients are having, or if people are having, men or women who are having family history of colon cancer, I think they should consult their gastroenterologist or a family physician, assess their risk of getting a colon cancer based on the family history, signs and symptoms, and if appropriate, getting a colonoscopy done will identify cancers in a very early stage. So we use a flexible sigmoidoscopy, that is a smaller version of colonoscopy, where the gastroenterologist sees only till the sigmoid, that is the lowermost part of the large intestine and the rectum. So they detect polyps if they are noticed in the lowest part of the or the farthest part of the large intestine. And if there are polyps, I think they'll do a full colonoscopy, and if appropriate for the particular patient, they'll repeat the test every 5 years. So these are the few most commonly used screening techniques. Again, not all people require screening at an early age, but if you have a family history of colon or rectal cancers, do consult your family physician, have an appointment with the gastroenterologist, tell your history, family history, any signs or symptoms, and if appropriate, they'll do a colonoscopy. The most common thing, as I said, is a colonoscopy. So this is a simple and safe procedure in which a long flexible tube with a light and camera at the tip is used to detect the polyps or ulcers or cancers. So all these things can be directly viewed. So for appropriate normal subjects also, we can use colonoscopy if they have a family history or any symptoms that are suggestive of colon or rectal cancers. So how do we stage actually these colon or rectal cancers? For you to understand, the simple way of looking things is there are curable stages, there are incurable stages. So any cancer that is present in the point of origin or within surrounding tissues of the point of origin, those cancers we call it as curable stages. If the cancer has spread from the point of origin to far away places or distant organs to organs that are not related to the point of origin or the source of the cancer, so those cancers we call it as incurable cancers. So stage 4, that is the highest stage. So where we see that the cancer has spread throughout the body to distant organs. In this case, for a colon or rectal cancer patient, if the cancer starts in the colon or the rectum and spreads to liver or lung or any other place, so we call that cancer as stage 4 colon or rectal cancers. So stage 4 colon cancers, based on the areas of spread like lung or liver and based on the number of organs that are involved, sometimes we give treatments that are only helpful in palliating or comfortable life to the patient. So for all other stages, that is stage 1, 2, 3, the earlier stages, our intention of treatment will be to cure the disease. So again, so stage 4 is incurable technically. We'll most of the times try to palliate or comfort the patient. For all the other stages, stage 1, 2, 3, depending upon the site of the disease, whether it is from the colon or it is from the rectum, we give 3 forms of treatments. One is surgery, that is, we try to remove the cancer along with some normal tissue around. So that is called surgical resection of the cancer. The second modality is chemotherapy, that is, we give drugs orally or through your veins, systemically, through the blood, where these drugs called chemotherapy drugs, they'll reach the site of cancer, they'll try to kill the cancer cells. So this is the second modality of treatment. The third modality is called radiotherapy, where we use high energy radiation. We'll target that high energy X-rays. Radiation is nothing but a high energy X-ray. So we target those high energy X-rays to the point of concern, that is the cancer. Radiation usually used for rectal cancers only, whereas for colon cancers, most of the times we use either surgery alone or surgery and chemotherapy. So stage 1, 2, 3, these cancers, these stages of colon and rectal cancers are curable. Stage 4, that is cancers that have spread to distant organs, are technically incurable, but still we can try to give medicines. Those are chemotherapy drugs, targeted drugs, sometimes immunotherapy drugs. to palliate the symptoms of the patient and to prolong the life of the patients. So these are the various modalities of treatment. Surgery, as I said, that is resection or removal of the tumor surgically. Radiation, as I said, we give to rectal cancers. Those are high energy X-rays directed against the cancer cells. Third one is chemotherapy, where we give tablets or injections into the blood, where the drug will travel in the blood and reach the cancer cells and try to kill them. Targeted therapy is that a cancer cell, we go to the DNA of the cancer cell, we try to identify what part of the DNA is damaged or what part of the genetic material is mutated, and we try to target that particular damaged part of the DNA across all the cancer cells. So that is called targeted therapy. And the most recent or advanced therapy is the immunotherapy, where we stimulate our own immune system, stimulate our own body's immune system, and try to kill the cancer cells with the help of our own immune cells. So that is called immunotherapy. This is the recent advance in the treatment of colorectal cancers. Not all patients require all 5 forms of therapy. Depending upon the stage of the disease, type of the disease, the general condition of the patient, we choose between these 5 different treatments. So to briefly tell you what treatment we use for stage 0 or cancers that have not formed, or if we see only polyps in the large intestine, we do polypectomy that can be done with the help of the colonoscopy itself. So that is the treatment for stage 0 or cancers that are not spread beyond the mucosa. Stage 1 is surgical removal of the tumor and the nearby lymph nodes. For stage 2 cancers, we do surgery followed by any additional drugs like chemotherapy agents that we call it as adjuvant. That is adding on to the benefit we have got from surgery. So we give surgery, we do surgery and give additional chemotherapy for stage 2 cancers. For stage 2 rectal cancers, we give radiotherapy and chemotherapy followed by surgical removal of the remaining tumor. For stage 3 cancers, we usually do surgery and additional chemotherapy, or we can give radiation and chemotherapy before the surgery followed by surgical removal of the tumor, and then we give additional chemotherapy based on the biopsy report. Or once the tumor is removed surgically, we again test it with the help of a pathologist and see the characteristics of the tumor, where all it has spread, what is the stage, what is the type of colon or rectal cancer, and based on that we try to give additional therapy also. For stage 4 cancers, as I said, stage 4 cancers are spread beyond the point of origin. Like colon or rectal cancers, if they have gone through the bloodstream to the lung or liver or any other site like bone, sometimes bones also get involved. So in those cases, we rarely use surgery and radiation. Most of the times we give chemotherapy or targeted therapy or immunotherapy. For sometimes, for some patients, even with stage 4 disease, we can try to cure the disease if the number of metastasis, that is, if only 1 or 2 lesions are there in the liver. Lesion meaning if the cancer that has spread to the liver is concentrated in 1 site or 2 sites, we can try to remove that also surgically. So very few stage 4 colorectal cancers can be attempted to cure by surgery or radiation. So this is the brief treatment as per the stage. The latest advance in the treatment of colorectal cancer is the laparoscopic usage. So these days we give a small keyhole sized incision on the patient's abdomen or tummy, and we give those incisions 3 or 4 places, and with the help of a small camera and that is fixed to a laparoscopic instrument, and with the help of the laparoscopic system without the need for major surgery or without the need for opening up the abdomen completely. We can do these laparoscopic surgeries with smaller incisions, with often guided by fiber optic cameras. So what is the advantage of laparoscopic surgeries over traditional cancer surgeries? The time for recovery is very, very short. So because we are not opening up the entire abdomen, the incision is very small. So that makes the patient ambulatory or mobile immediately after surgery, and that will help in recovery more quickly. So depending upon the site of the cancer, they'll remove the appropriate anatomical part of the colon. So sometimes if we cannot completely remove and re-anastomose, meaning if we can cut the abnormal colon area and stitch the other two ends, we can avoid doing a colostomy. What is a colostomy? If we cannot spare or we cannot completely anastomose the normal ends, sometimes we try to create a newer outlet. So usually the digested food after absorption of water comes out through these sigmoid, large intestine, sigmoid colon, rectum, and anus. So if sometimes for one reason or the other, if we cannot spare the rectum because, or the anal canal, if the cancer is very near to the anal canal, we might sometimes have to completely remove the anus also. In those cases, we put a stoma, that is, we create a newer outlet across the abdominal wall. So patients sometimes they carry these stoma and colostomy bags, so that we call as colostomy. Creating an artificial outlet on the abdominal wall is called colostomy. So the need for colostomy depends on the patient's stage of the cancer and the location, anatomical location of the cancer. Chemotherapy, there are various chemotherapeutic agents that are active and that can kill the colorectal cancer cells. So the cancer specialist who is treating your cancer decides on what combination of drugs you need to get. If you need to get targeted therapies, if you need to get immunotherapies, these are all the latest developments in chemotherapy, or the systemic therapy we call immunotherapy, that is stimulating our own immune system against the cancer cells and trying to kill the cancer cells. So after knowing about the treatments, diagnosis, and various surgeries and chemotherapies, what can we do? As we said, there are some modifiable risk factors which can reduce our chances of getting a colon or rectal cancer. So what all can we do? We can actually eat a lot of diet rich in fruits, vegetables, whole grain, fiber, so that our bowel and bladder gets emptied at regular intervals, and making sure that bacteria and other gut flora, gut bacteria that is harmful for us, and that which can cause colon or rectal cancers in the future gets washed away daily. So one good thing what we can do is, and which is there in our hands, is eat diets rich in fruits, vegetables, and whole grains. And we have to be aware of our family history. If someone has got a familial colon cancer, I think right time is now to get an appointment with the gastroenterologist. Tell him your risk factors, and if appropriate, he'll do a colonoscopy or a stool occult blood to know if there is any risk of you getting colon cancers. The other thing we can do is being physically active, keeping our weight in control, doing regular exercises. So all these are preventable things which we can do in our routine life. Smoking, absolute no, because smoking or use of tobacco, not just colon or rectal cancers, it can cause around 15 to 16 different types of cancers. So smoking is a big no. Alcohol, again, in conjunction with smoking, alcohol and tobacco together, they have a synergistic activity for people to get cancers. So both together, they cause around 20 different types of cancers. So quit smoking and limit your alcohol usage. And who should be screened? For average risk patients, that is people without having any colon cancer history in their family, they can get screened after the age of 50 years. And if we don't have any polyps history or no family history of colon or rectal cancers, after the age of 50, I think we can get a screening test, basically at least a stool occult blood or the guaiac test, where we see if there is any blood loss in the stool. Who should be screened at a younger age? That is, if someone is having a family history of colon cancer, or if someone is having, as I said, those signs and symptoms of colon cancer, like unintentional weight loss or a low hemoglobin, alternating bowel habits like constipation and diarrhea, unexplained abdominal pain, which is lasting for more than 2-3 weeks. All these people should be screened for colon or rectal cancers. If we have a first degree relative, that is our mother, father, or son, daughter, or these are first degree relatives. So we should start getting screened at an earlier stage, earlier age of our life. So if someone of our first degree relatives have a colon or a rectal cancer, I think the screening should start ideally at 40 years of age, at 10 years before the routine screening at 50 years. So you should start at 40 years, or if your first degree relative has got colon cancer or rectal cancer at, let's say, 44 years of age. So 10 years younger than that age at diagnosis. So if your family relative is diagnosed with colon cancer at, let's say, 42 years of age, you should get screened at 32 years of age. That is 10 years before the diagnosis date. So if some of your family members have got polyps, colonic polyps, or inflammatory bowel disease, all these things, I think the screening age should come down to 40. So to summarize what we have learned today, colon cancer is a very common cancer. In India itself, we get around 70,000-75,000 new colon cancer patients in a year, and half of them can be prevented. It is a very treatable cancer. Even in later stages also, we can try to comfort and palliate them, if not cure them. Screening should start at 50 and go up till 75 for an average risk adult. And if there is a strong family history or history of colonic polyps, screening should start at an earlier age. And if there is a family history and a high risk personal history, that determines your risk of getting a colorectal cancer. Screening and colonoscopy can prevent cancer by removing precancerous polyps and detection of the cancer in an early stage, and that can be treated easily. A healthy, high fiber diet, exercise, limiting your alcohol usage, quitting tobacco can lower your risk for developing colon or rectal cancers. Those are all the modifiable risk factors that are in our hands. Colorectal cancer screening rates must be optimized to reach the aspirational target of decreasing the incidence of more than 80% of colorectal cancers. So screening must be made aware to common public like you through these platforms. And we come on the special occasions like the Colorectal Cancer Awareness Month in this March to create awareness among the general public. And it is up to the public to be aware of their body, be aware of their GI system, and if appropriate, get an appointment with the doctor and get screened for identifying these deadly cancers at an early stage, so that the treatment is easy, the disease can be completely cured, and you can live a healthy, normal life. Thank you.